profesor, el doctor Albert Arrubia, el cual es profesor adjunto de la Escuela de Cirugía de la Universidad del Oeste de Australia. Bueno, ustedes lo han visto que es una persona particularmente en una actividad mental en cuanto a temas de coagulación y por supuesto en temas especialmente dirigidos al tema de hemofilia, el tema de conocimiento de los concentrados y algo que es impactante que yo escuchaba en la mañana, él habla muy bien en el sentido de el paciente, preocuparnos por el paciente. Hay terapias generales, pero él habla muy bien de que la terapia tiene que ser personalizada, ¿no? Como decimos coloquialmente, no hay enfermedades si no hay enfermos. Creo que es algo que él ha venido continuamente enfatizando en todas sus charlas. Y bueno, Albert Arrubia tiene una cantidad que ustedes pueden poner en el PubMed. Arrubia van a aparecer artículos interesantísimos, algunos review importantísimos de hemofilia. Yo lo conozco a él y yo lo invité porque lo conozco simplemente por lo que he leído de las referencias que él tiene y lo he conocido en algunos congresos internacionales. Así que para mí es un honor nuevamente presentarlo, que tenga pena presentarnos su tema en el día de hoy y que estemos muy atentos porque además tiene una cualidad, o como lo queramos ver, un problema para la traductora, habla muy rápido, ¿de acuerdo? Así que bueno, Albert, muchas gracias.
Well, thank you, dear Carlos, and I will try. Everybody has always told me I talk very fast, and I think this is very hard on the interpreters, mostly. And I know that our interpreter is really very good, so I will try to be better. Now, I didn't know exactly how to approach these two talks, which it said comida. I thought it meant some kind of lunchtime symposium. And I thought I would be standing here and you people would be eating. Now, I am standing here, you people are not eating, so I hope you are not too hungry. Okay, so look, there are two talks. And what I will do, Carlos, if you think it's okay, we'll do one talk, stop for questions, and then do the other talk. And you will find that, again, many of the topics have been already approached, so we will not take as long as would otherwise be the case. So this first talk is about the general area of approaching a choice for products. You can see here the evolution of the treatment of hemophilia over the past 70 years or so. We have seen huge advances. Although the observation that hemophilia could be treated by replacing a missing component in the blood is actually quite old, until relatively recent years, this could not be exploited because we could not understand the biochemistry of fractionation of blood. So before the 1950s, we could only give blood transfusion. Over the 1950s were developed the first concentrates. They were developed by the group in Sweden which supplied Professor Inga Maria Nilsson with the first products. These were the husband and wife team of Birger and Margarita Blombach, very great people, and they gave this knowledge to the world because later they also went to other countries outside Sweden and even came to Australia in 1962 to teach how to make this concentrate. But this concentrate was only able to be made in an industrial facility, so it was not very easy to make it in an accessible form until we had the development of cryoprecipitate over the 50s and 60s again by a French doctor who was very unknown, and this discovery was made again by Judith Poole in 1965. This was the biggest revolution so far in the treatment of hemophilia. No other discovery has made such a big difference to the community as the discovery of cryoprecipitate. You all know this. As a result of this cryoprecipitate discovery, the cryoprecipitate could be made in blood banks. That means it could be given to a lot of patients, and it could also be made industrially in factories, which gave us our first concentrates. Concentrates were better and still are much better than cryoprecipitate, because in those days cryoprecipitate was frozen, you had to keep it in the fridge. Concentrates could be kept in a freeze-dried form as a powder, reconstituted by the patient, and that is how we got home therapy. Over the 1970s and 80s, the life expectancy of people with hemophilia increased greatly because of these products, but in the 1980s we had developments which you know of, which had a bad effect on this progress. And these were the viral transmissions, the viral epidemics of HIV and the hepatitis viruses. These were overcome, and at the end of the 1980s, we had the next revolution with the development of recombinant products. Since then, the treatment of hemophilia has been one long series of increasing success, because now that we have recombinants, we also have the capacity to change the molecule to make it more able to treat well the patients. So in my talk, I'm going to first talk about supply, and then I'm going to talk about safety, and in this way approach some thoughts on how to choose from the large number of products which we now have available. This is a very, I think, illustrative slide. It is a very educational slide. It was developed by the WFH about 15 years ago, and it shows the relationship between the prevalence of hemophilia and the amount of factor VIII available to treat it. So this is actually a survival curve, because you can see that the prevalence starts to go up when you start to provide treatment. And between 0 and 1 international units per capita, we have the survival going up very remarkably, the prevalence goes up very remarkably, and then when we increase further, the prevalence goes up, but not such a fast rate. And this shows us that the provision of 1 IU per capita really makes the patient survive. It prevents death from bleeding and gives some more benefits. But then, if we go beyond that, although it will not have such a big effect on survival and therefore on prevalence, it will have a big effect on the quality of life. It will mean if we have more than that amount of 1 IU per capita, we will have better prophylaxis, we will have the ability to do joint surgery, and we can then start approaching also, the more we have, the tolerization of patients to inhibitors. So this is, as I said, just a position of how supply of factor VIII affects survival. This shows us the huge increase in the usage of factor VIII in these past 30 years or so. And as you can see, this huge increase is mostly due to the huge consumption of recombinant factor VIII in the rich countries. Today, countries such as Australia, United States, Sweden, Germany, and so on, all consume more than 7 to 8 international units of factor VIII. Sweden itself consumes about 11. Much of this factor VIII is the recombinant. But this does not mean that plasma-derived factor VIII is not important, because you can see that actually the amount of plasma-derived factor VIII has also gone up. So my first message in this talk is very simple, that both types of products are immensely important, and both have a role in the treatment of patients. And we will discuss a bit further on how we position the products in relation to their roles. As I've said before, having these better treatments has increased the life expectancy of people with hemophilia. And you can see how this is shown diagrammatically on this slide. In 1900, the life expectancy of a person born with hemophilia was about 13. This is because obviously bleeding becomes worse as the Boys grow up, become teenagers, and they bleed to death. By 1960, this had improved to about 20 because of the understanding on how to treat some bleeding, not through necessarily the concentrates, but through better medical care, but still very short. By the time the 1990s came up with the huge revolution in supply, which I spoke about earlier, we have a very much increased life expectancy. About 10 years less than the average life expectancy of a normal male in the United States. And today, having gone through the bad situations of viral infection, HIV and HCV, and being able to treat the problem of inhibitors to a large extent, in the developed economies, in the rich countries, the life expectancy of men with hemophilia is basically expected to be the same as that of the general population. I am a little bit hesitant when I make this remark because, as I've said, men with normal life expectancy with hemophilia are, if I may say, a new phenomenon, and we still do not understand exactly what the future may hold in terms of what nature may do to try and solve the problem of the hemophilia gene. And the problem to solve the hemophilia gene is to basically have no hemophilia. Right. And it's not only in life expectancy that this has become a much improved situation. As I said, with 1 IU per capita and a little more, we approach the life expectancy optimization. But the quality of life requires more. And there is no way that you can show better the improvement in the quality of life than to show these two photographs, which many of you have shown. These are from the Netherlands. You can see here the boys in the 1960s in a summer camp. They are having a nice time, they are outside in the open air, but unfortunately many of them are still in beds, bedridden. And here you can see the situation today of this group of young children with hemophilia playing basketball as if they are normal boys because they have availability of treatment. But this is not the same everywhere, and this was referred to earlier on this morning, because like everything else in this world, there is inequality, and there is a big division, of course, in access to care in every disease between the rich and the poor countries, and this is obviously the case with hemophilia, which is a rare disorder where the products are quite expensive, and therefore it is not easy to achieve priority for hemophilia in the minds of health decision makers in the poorer economies. And we know that as a result of this, more than 2/3 of the population of the world receives no treatment or at best inadequate treatment, and this kind of picture is the result. And you have seen these before from the situation developed by the WFH to try to address these huge problems. These are pictures which, even in our countries, in the rich Western economies, were not uncommon 50 or 60 years ago, but today they don't exist for us. These exist, though. These are pictures taken in these years, these past few years, in countries such as Pakistan, Afghanistan, and other countries where access to care is very low. So we still have a lot to do. So that was my first comments about supply, and I make this point about supply because to me, the recombinant products, their importance is not in safety, and we will discuss a bit more the question of safety and inhibitors, but the importance of the recombinant products is with supply, because with the recombinant products, hypothetically, we can approach a situation that there will be no person with hemophilia in the world who is not treated, because the supply is infinite. All you need is the cells, and you feed the cells. This is putting it simply, but it is really the truth. In relation to the plasma products, they are good products, but they are always limited in supply because they come from blood and plasma, and there is never enough for the treatment of hemophilia, never enough. if we were to take all the factor VIII out of all the blood and plasma donated in the world today and distributed over the whole world population of people with hemophilia, we will have a global IU per capita of 0.66, and that is obviously not enough. So we can never have enough factor VIII through the plasma, but the plasma supply factor VIII is very important and we have a role for it. But theoretically, the factor VIII from recombinant is infinite, and I'm going to make a few more points about this in the second talk. So now I talk about safety. And traditionally, historically, safety for hemophilia has meant, in terms of the concentrates, safety from viral infection. And this is a very famous survey, a very famous study from the Centers for Disease Control in the United States, and this shows the relationship of viral infection positivity to the year of birth of the hemophilia cohorts in that country. And the important point made by this slide is that after 1984, there was no more HIV detected in the hemophilia population. Remember, this is the United States. And after 1992, no hepatitis C detected in the hemophilia population. 1993, no hepatitis B. This is a remarkable achievement now. We are a quarter of a century from having any infection in the developed economies from viral transmission as we used to have before. And we have a very interesting situation because we have had a turning by 180 degrees between the safety of blood components for transfusion and the safety of hemophilia products. Because you can see from this slide that at the same period that there was no HIV transmission from hemophilia products in the United States, there still was transmission from human immunodeficiency virus from blood transfusion. And this is because during this time, although there were tests and there were selection procedures, there was not inactivation of the virus in the transfused red cells, plasma, platelets, and so on. What has made the difference for the community of people with hemophilia is very simple. It is viral inactivation. Tests are important. Selecting safe donors is important. But the most important thing in the plasma-derived products is viral inactivation. This is what made the difference in terms of transmission, and this is not yet available in blood transfusion, not just for established and very famous infections like HIV, but it's the same situation with emerging viruses, nowadays not so emerging, it's been around for some time, like the West Nile virus, which you can see in the United States still has caused many infections in blood transfusion, but not one single infection in hemophilia patients and other recipients of plasma products. This is a very important point because we are always getting more and more viruses. Nowadays, the virus du jour, to say in French, is, Zika. Well, we think Zika can be transmitted by transfusion, but there's never been evidence of Zika in hemophilia. This is a remarkable achievement, but again, it's not all over the world. This shows the situation in terms of the transfusion-transmitted diseases in the hemophilia population in Western India. And the point is, you can see what these patients take for their treatment. Because they don't have much concentrate, they take a lot of whole blood and cryoprecipitate and fresh frozen plasma from local blood transfusion banks in India, Indian blood donors, and the infection rates are much higher. And this is not because the donors are paid or anything like that, it is because there are incipient endemic infections in these donors. So in the community of people with hemophilia in India, we still, in these days when there is no problem in the Western economies, we still have people being infected because of the lack of safe concentrates. This is an important point. But overall, the question of the safety from transfusion-transmitted diseases has become not so important for the reasons I have told you. And what we have now as the biggest issue in terms of safety and choosing the right product is inhibitors. And I am very happy that much of what I wanted to say has been covered by Professor Peyvandi, so I will not have to repeat too much. But inhibitors, even in the rich economies, are still very much a problem, and you can see here that in mortality in the United States, patients with hemophilia A with inhibitor have much higher mortality than those without inhibitors. 3 times as much. You can see how significant this is. And this is obviously very important. We still have this epidemic, we still have this big problem of inhibitors. If you look at the patient outcomes, you can see this set of data here from Lessinger in the United States. You can see patients with inhibitors have much worse joint status. And if you look at quality of life as assessed by the patients themselves, you can see that the patients with inhibitors consider that they have much less quality of life because of lower mobility, lower ability to self-care, lower ability to do daily activities, more pain, and more anxiety. So inhibitors are really our big problem today. I think Professor Peyvandi showed you very well what we think as the background reasons for inhibitors. Much of the reason for inhibitors is linked to the patients themselves, high risks from the type of factor VIII mutation that they have, and we know that there are some mutations which are much higher in terms of inhibitor risk. We also know that ethnicity, such as African heritage in the United States, increases inhibitor risk. And we have, for many years, had this issue of does the type of product we choose induce inhibitor use. What we also should keep in mind is not just the things which increase the risk of inhibitors, but the things which decrease. And it is interesting to see that there are several studies, including the Rodin study on children in many centers, which show that prophylaxis decreases the incidence of inhibitors. So this is another reason to consider prophylaxis, that patients on prophylaxis get less incidence of inhibitors overall. There are some studies which contradict this, but overall this is the situation. So if we think about inhibitors, what shall we do in relation to the goals for these patients? Well, first of all, we need to consider the treatment of acute bleeds. If a patient with inhibitor has an acute bleed, he has to be treated there and then. That's obvious. So let's look at acute bleeds. Acute bleeds are treated with the so-called bypassing agents. And of these, on the mercato, on the market, there are at the moment 2 types. There is FEBA, which is produced these days by Shire. It is produced from plasma, you know, and it is a mixture of activated coagulation factors. And then there is Novo 7, which, as you know, is a recombinant product. It is factor 7A. For many years, there has been a big fight between these 2 companies, between Shire and Novo Nordisk, as to which is the best product. Probably, this is a stupid fight, because some patients react better with one product, some patients react better with the other product, and overall, the so-called PHENOX study, by Asterman in Sweden, showed that overall, there was a similar effect on joint bleeds, although I have emphasized the efficacy between products is rated differently by a substantial proportion of patients. As I said, although overall, if you look at 2 populations, one on one product and one on the other, you will get similar effects. If you look within the population, you will find patients who are better with one product and with another. Another example of the importance of the personalization of treatment. If we look then at the question of prevention of bleeds, so we're looking at a situation here which is really very similar to patients who are without inhibitors. To treat acute bleeds, we give on-demand therapy, but to prevent bleeds with patients with no inhibitor, we give prophylaxis. And now there is a strong indication that prophylaxis can also be done with the current bypassing agents. And you can see here, this is a study which shows that with activated prothrombin complex concentrate, which means FIBA, prophylaxis gives a much better result relative to on-demand. However, the amount of bleeding with prophylaxis with the current measures that we have, FIBA and NOVO7, is higher than the amount of bleeding of a patient on normal prophylaxis without inhibitor. There is no question of this. So recently, and I think this has been also described to you, we have seen this very interesting drug has been developed by Roche, which is this humanized bispecific monoclonal antibody, haemophilia. And this seems to be quite promising, and it was the latest trial, which was described this morning, the Haven one, was published in the New England Journal of Medicine just 2 months ago. This drug is basically a monoclonal antibody, so this has nothing to do with factor VIII. It's not a coagulation protein, and you know that it works by bringing together the factor 10 and the factor 9A, so that, like factor VIII, it acts as a bridge between the enzyme 9A and the substrate factor 10 and restores the generation of factor 10A. There is a lot of interesting promise with this drug. One of the most interesting aspects is that this drug is administered subcutaneously once a week. So you have a very big advantage in terms of patient convenience. Also, with the data coming from the Haven 1 study, you can see that prophylaxis with this new drug gives much lower ABRs, annualized bleeding rates, than prophylaxis with the current bypassing agents, FIBA and the NOVO7. So this drug appears to be very promising. There is a huge interest. The community is looking to see if this promise develops further and we can see this drug on the market. Then, of course, the next question is going to be, how much does it cost? This is a new biotechnology agent. It has cost a lot of money to develop, and I think, of course, it will not be cheap. The third point about inhibitors, therefore, is now to cure, inverted commas, to cure the inhibitor, to remove it. And this, as you know, is through tolerization, through immune tolerance induction. This is a therapy which is successful in the majority of patients with hemophilia A. It's by no means, I haven't said much about inhibitors to factor 9 with hemophilia B. It's not so much successful as you know with hemophilia B. Inhibitors to hemophilia B, although very rare, are one of the biggest problems in hemophilia therapy. So I think that I don't have to go over this. I think it was shown. These are the various treatments, regimens for inhibitor tolerization with hemophilia A. They are all quite hard on the patient. They are arduous on the patient. They involve daily dosages of huge volumes of coagulation factor. It's not easy, and it's very expensive. We will talk about the cost in the second talk. There is, however, and has always been, a question of the product, and you know that this morning Professor Peyvandi gave you background in relation to the role of von Willebrand factor in protecting the factor VIII molecule in relation to the immune response in hemophilia. And this is also based on clinical observation. And here is a paper. This is from Oldenburg in Germany. This is just a single case report, but I like the way in which it is demonstrated, in which you can see that this patient with inhibitor, who had obviously a very short half-life of the factor VIII, his concentrate was recombinant, and when it was changed to a plasma-derived factor VIII, hemate-3, which also has von Willebrand factor, the inhibitor went down remarkably, and the factor VIII assumed a normal half-life. So this is an indication, but remember that this is a case report, not a trial. Flora Peyvande this morning spoke about the mechanism of the way in which von Willebrand factor may protect the factor VIII, and it is also shown on this slide, in which you can see that the ingestion of factor VIII by the antigen-presenting cell is very efficient when there is no von Willebrand factor, such as is the case with the recombinant factor VIII, but is not so efficient when there is the von Willebrand factor. And if the ingestion and presentation by the antigen-presenting cell is not so efficient, this will make the immune response less efficient as well. And this could give a partial explanation, perhaps, to the fact that the von Willebrand factor concentrate may decrease inhibitors. Nevertheless, it is the case that for the past 20 years, the most controversial risk factor for the development of inhibitors has been the type of therapeutic molecule. And this has been a big controversy as to whether plasma-derived or recombinant factor VIII have a role in the inducement of inhibitors. I want to emphasize that the concentrates are not the reason for getting inhibitors. The reason, the causes, the etiology of inhibitors lies inside the patients, not inside the products. The patients will get inhibitors. The question is it the type of concentrate going to make this situation perhaps higher risk or worse? So we have these recombinant products which until recently were all produced in mammalian cell culture. They're very high purity. As I've said before, the big advantage is that they are able to be infinite in supply. These cells are very efficient. You give them food, they continue making factor VIII till we are all dead, and all our children are dead, and our grandchildren are dead, and the cells are still there making factor VIII. But they do have differences, these mammalian cells, from the normal human factor VIII. And the big difference is in the so-called glycosylation, glycans which are linked to the protein molecule, which in many instances are absent in these cells or are very different, and also other modifications such as post-translational modifications involving the sulfation of the molecule, phosphorylation of the molecule, which are different in these cell lines. So they are different molecules. This is the whole point. Although we call these recombinant factor VIII, really it's probably better not to call them factor VIII because they are actually different molecules. And this is a very famous slide, everybody uses it, and this morning Peyvande showed it to you. This shows a summary of observational studies. So these are not clinical trials, okay? So we've got here the observational studies for the incidence of inhibitors with the plasma-derived and the observational studies with the recombinant, and you can see that with these observational studies, overall, the plasma-derived have less than half the incidence of inhibitors than the recombinant products. These are observational studies. The people who are very strong supporters of evidence-based medicine do not like observational studies. I personally like observational studies because I think the basis of science is observation and measurement. However, it is thought that randomized clinical trials are better. We will discuss that. I wanted to make a point, because this is supposed to be the seminar of Kedrion, that the Kedrion product, CLAHT, which I believe is present in Mexico, has a low inhibitor incidence as far as we know through the studies which are available. It is only 7%. It does have a von Willebrand factor component. I want to emphasize that it is not unique in this level of incidence. Many other products from other companies also have this low incidence. Many other products, which I think you have in Mexico, from other companies which provide plasma-derived von Willebrand factor containing factor VIII, also have these low levels of inhibitors. But this is a study with hemoglobin. Now, this slide was shown by Flora in a different way. This is a meta-analysis from Alfonso Iorio, and in this meta-analysis he combined all the trials and all the studies he could find between plasma-derived and recombinant factor VIII, and he found that, in fact, there was an incidence rate of 14% for the plasma and 27% for the recombinant. But after multi-way analysis of variance, because of the significant differences in the study designs, periods, frequencies, etc., between all these different studies, this lost the significance. So Yorio made the point, which is a perfectly good point, that this underscores the need for randomized clinical trials, for randomized controlled trials, because in a randomized controlled trial, as was shown by Flora this morning, these variations in study design, study period, and so on are removed. We don't have any of these gaps. And I don't have to tell you now about the randomized controlled trial. This was shown by Peyvandi. This is the CLAHT paper. You can see the result over here, which she showed you in terms of the gradual incidence increase in inhibitors between the two groups. And you can see over there the conclusion from the authors that the patients treated with plasma-derived factor VIII containing von Willebrand factor had a lower incidence of inhibitors than those treated with the recombinant product. I don't have to say anything more about the study. You had the best person in the world to tell you about it this morning. But I do wish to make some further comments, although she made them also herself, about how we use now the study, because this emphasizes the point I was trying to make about the stock, product choice. So what do we do now that we have this study? Well, this is, of course, the first randomized clinical trial to demonstrate that the risk of inhibitor is nearly doubled when using the recombinant product. This is not a good thing. Now remember that this inhibitor incidence was found in PAPs, in previously untreated patients. This is not the case with the previously treated patients. Inhibitors arising in previously treated patients are actually very, very rare. Okay? So the important thing for the study CPIT is PAPs, young children, babies, basically. And as I've explained, inhibitor treatment is a very bad thing to happen. It's a catastrophic event and has very bad effects on the patient well-being and also on the budget of healthcare systems, because to treat an inhibitor, a patient with inhibitor costs millions of dollars to either treat with bypassing agents or to tolerize. So it's something which, whatever we can do to decrease the risk, we should do. And therefore, my feeling is, and there is a big controversy on the CPIT study, this is my opinion, is that we need to minimize the risk of inhibitor, and the way to do this is perhaps to use the plasma-derived von Willebrand factor concentrate, as was explained by Professor Peyvandi, for the first 50 exposure days of treatment. So that when we come to choose the product, if we have a patient who is a young baby and we don't want to increase the inhibitor risk, it should be considered strongly that a plasma-derived product with von Willebrand factor may decrease this inhibitor risk. And you remember what Flora said about the other risks related to genetics. And you could see that in the CPIT data, the high-risk genetics patients for inhibitors who got plasma-derived, none of them developed inhibitor. And I think this is an important observation which needs to be very strongly kept in mind. This is an example, in my opinion, of the vow which we all take when we become doctors of primum non nocere. The first, do no harm. And this is something to be taught about. In terms of product choice, again, this is again the slide which summarizes the various products which we have now on the market. It is an incredible situation for those of us like me who have been involved with hemophilia all their lives. It is incredible that from the few plasma-derived products which we had 30 years ago, many of which were not safe and none of which were available in sufficient supply, we now have this huge number of products, many of them the result of the marvels of biotechnology. This is a good situation. The thing which stands in our way now is not supply. The thing which stands in our way is not safety. The thing which stands in our way is access, it's money, and that's the subject of the next talk. And so I will end this talk by summarizing the situation as I see it of product choice in the current era. And I think that all hemophilia treatment products approved for the market through the regulatory agencies like FDA and the EMA and the agency in Mexico and so on, are safe and are effective. In developed countries, inhibitors have become the main primary adverse event, and they are now classified by the European Medicines Agency as being very common. This is a very common effect. Even if you think about the CPID and the plasma-derived, 26% incidence, 1/4 of patients will get inhibitor from plasma-derived. So this is a big, serious issue. And the optimal therapeutic strategy is to remove the inhibitor. We don't want people to say, oh, you don't need to remove the inhibitor because there is this new drug and it bypasses it. No, the best thing to do is to remove the inhibitor. If we have a new drug, it's good to treat the bleeds while we are removing the inhibitor. Otherwise, if we don't remove the inhibitor and we have something which is bypassing the inhibitor and the patient needs an operation, the patient is in an accident and needs a vast amount of factor VIII, the new drugs will not work. They will the factor VIII will be neutralized and the patient will be in deep trouble. And as I said, in my opinion, the first 50 days of exposure of treatment of PAPs should be done with the plasma-derived concentrate. This is my opinion. This issue is a strong debating point in the community. I look forward to continuing the debate. I will stop here, Carlos, and thank you for attention and take any questions.
Muchas gracias al doctor Albert. Si tiene alguien alguna pregunta, comentario, plática, queja, él es un profesional muy afable, creo que no hay ningún problema que lo pueda responder. Ana, ¿vas a comentarlo?
Me llamó la atención el comentario de lo que podría ser un poco contradictorio de la aparición de inhibidores en niños cuando se realizaban las profilaxis y que sin embargo era el hecho de elección. ¿Por qué es así? ¿Qué fue lo que encontraron? Y esto de los inhibidores a todos nos tiene muy asustados. A ver, en realidad, personalmente, ¿qué cree que es lo correcto para actuar en estos casos? ¿Trabajamos con los recombinantes o seguimos como hasta ahora con los derivados plasmáticos?
Well, the question of prophylaxis is still controversial in relation to inhibitors because although there has been randomized studies for prophylaxis versus on-demand to measure bleeding in joints, there's never been a randomized study to assess whether inhibitors are lower or higher with prophylaxis versus on-demand. And it's very difficult these days to actually think there may be such a study. So all we have are prospective surveys, like the Rodin. In other words, patients are treated, there is no randomization with whatever is available, and inhibitor status is assessed. And the majority of these suggest that normal prophylactic regimens have an effect in decreasing the inhibitor incidence. Now, having said that, there is still doubt. Because of this observation, actually a trial was conducted. A trial was conducted by Professor Gunther Auerswald in Bremen, in Germany, because he formed this hypothesis based upon the clinical observations which he had made, he and his colleagues, that he could actually tolerate patients immediately when they are still very young, before they actually have inhibitor, by giving them prophylaxis at a very young age to expose them to the factor VIII and make them tolerant. This sounded like a good biological hypothesis, and he had some preliminary data to support this. Unfortunately, when the trial was actually conducted, it had to be discontinued because the babies which were on prophylaxis, remember, this was prophylaxis without bleeding, they were immediately exposed to the factor VIII as soon as there was diagnosis. Unfortunately, more of them developed inhibitor. So the hypothesis dropped, and this has made the whole question of whether the prophylaxis is protective to be a bit more dubious. We still have, though, these observations from the Canal study, from the Rodin study, which seem to be fairly persuasive. I myself am reasonably persuaded. Now the question as to which product to go to, again, it comes back to how strongly you believe in the CPIT. I think that the CPIT is a strong study conducted in the methodology which we expect to be conducted, and I think therefore that because of this huge problem that we need to give the patients what we call the benefit of the doubt, that even if we have doubts about CPIT or whatever, the consequences of inhibitor are so large that I think that in terms of not doing harm, when the patients need to be treated, for the first 50 days, we should consider strongly treating with the plasma-derived. Afterwards, you can treat according to the literature with whatever you like. I emphasize that both product types are desperately needed. If we consider the situation of economics, strangely enough, and I will tell you later why strangely, we have the plasma-derived cheaper than the recombinant, so they're important. If we consider the CPIT, in terms of this question of the immunogenicity, they are also important. But in terms of the future of hemophilia treatment, if we for a moment do not take into account gene therapy, which is also very promising, in terms of replacement therapy, we cannot depend on the plasma-derived for the whole world because there will never be enough. And remember this, all of you involved in hemophilia, inhibitors are a very bad thing, but what has continued to kill people with hemophilia in the countries which are poor like India and China is no treatment. And there is no way that a country like China or India will ever have enough factor VIII from plasma-derived. So I don't know if I've got anything more to say about that, Anita, but this is my opinion. This is why we have doctors, to make judgments based on their experience and not based on numbers.
Sergio.
Gracias, Carlos. Nuevamente, muchas gracias. Nuevamente, muchas gracias por su excelente exposición. Mi pregunta es, los 50 días de exposición sabemos que son los críticos para el desarrollo de un inhibidor, pero con relación a esto también con la edad del paciente, por lo siguiente, nosotros hace poco en Durango rescatamos un paciente que estaba en la sierra, en los montes de Durango, tenía 20 y tantos años, un paciente que estaba arrumbado en un rincón de la choza, lo rescatamos y le iniciamos un tratamiento. Anteriormente había recibido plasmas y cosas de ese tipo cuando lograba bajar de la sierra y se regresaba. Entonces empezamos a los 25 años sus primeros 50 días de exposición. Yo sé que es difícil para ustedes la pregunta, bueno, supongo, porque obviamente esto no se da en países avanzados, pero es todavía un paciente en esta situación que está en sus primeros 50 días de exposición, independientemente de la edad, tiene ese riesgo parecido al de los niños que empiezan su tratamiento a temprana edad.
This is a totally excellent question, and it's true that I cannot answer it properly, but it is a very good question, and it is now an